hasn't come across me yet, so I just gave a talk downstairs. So I'm actually a graduate of the University of Cairo and happy to be back. So thank you so much for the invitation and letting us participate here. The other thing is that this is a topic that's quite dear to me because essentially it was the first topic that I was started off when I was a fellow in training in the US with research. So I was given a topic on the, essentially to address a question here, and you'll see some of the work that was done. So when these workshops were set up, Dr. Yasser Abdulhamid wanted to have a specific one addressing patients coming to transplant with proteinuria. How do we deal with them, what to do? And the way that we thought we'll deal with this is we're going to split it into two halves. I'll start off with a case and a little background, and then I'll give you Dr. Christian Hanna, who's a pediatrician. So for us, the cutoff is age 18. I only see people 18 and older. And Dr. Hanna is a person who sees pediatrics, so it's under 18, so 17 and below. And they have their own unique troubles in pediatrics. We have our own somewhat overlapping in adults. And we'll show you some long-term data of what was done in the past, and he'll share with you some updated component for it for pediatrics, because I know here in transplant is essentially, you've got pediatrics and you've got adults as well. One key thing is we really like this to be interactive. These are interactive workshops. So we're going to be asking you questions, and we hope that you answer and ask us questions, and we'll be happy to stop and move as we need to. So this is the pre-transplant management workshop with the proteinuria part. And I'll start off with this gentleman. So he comes in at 18 years of age with a failing kidney function, native disease, as attributed to FSGS. They're not yet on dialysis, so they're hoping to get a preemptive transplant, which is where we try to get everyone transplanted before they need to go on dialysis. They have an eGFR of less than 15, so really poor function and really should get transplanted soon. When you go ahead and do some testing for them and you check the protein in the urine and you check their serum albumin, they have 3 grams of protein in the urine in a 24-hour urine collection and a serum albumin of 3. So it's low but not too low. And the urine is high, but it's not massive nephrotic syndrome, but remember the eGFR is low. And then they present for a pre-transplant visit prior to a scheduled living donor transplant. So they've already been evaluated, approved, and then now you're asked to say, should they go ahead with the transplant that's scheduled for tomorrow or not? And so what I would like to hear from you is what your thoughts are regarding the proteinuria that you're seeing right now. And would you say just go ahead to transplant tomorrow, or what would you be considering here? Any thoughts?
So this FSGS is biopsy proven?
Biopsy proven FSGS, histologically FSGS with...
Primary?
What's primary?
Primary FSGS?
What's primary?
Diffuse replacement for process.
Okay, I'll give you that.
Nephrotic syndrome.
So all the glomeruli have sclerotic lesions, and they have diffuse food process effacement.
He was at any time nephrotic.
Good.
Edema.
Yes, previously massively nephrotic. Okay.
So he should be counseled about the risk of recurrence, maybe 30%.
Okay.
This all what we can do.
So you're going to counsel him on high-risk recurrence?
There is a probability or chance of recurrence of the original disease.
Okay, so there's a risk of recurrence of disease. Are you worried about this proteinuria right now? Would you let him to go to surgery tomorrow? If yes, why?
Nothing I can do with that.
Any? It's a little low, it's slightly low, 3. Others? I'll start picking on people. So you're thinking of preemptive plasmapheresis. Okay. I can give you that. Some people do it, some people think it works. The data is really wishy-washy, but you might want to freeze them. Okay. Anything else? Anything at all? Okay. We move ahead, so just keep those thoughts in your mind. So you go ahead and say, okay, I'm letting you go to transplant. So you go ahead and okay the transplant, and you don't do any plasmapheresis or anything. Then he gets the transplant, kidney function improves, and then you're busy doing other things, and then you check on the person, you're just looking at labs every day, and then you figure out on almost a week out that you didn't check a urine protein. Do you want to check urine protein on this patient sooner?
Yes, from day one.
Day 0 for us, so just the day of the surgery. Excellent, excellent, excellent. So there's a point there, which is, this is a preemptive transplant. They're making urine. So you get this 3 grams of 3 grams, you do a spot check, so it's about 3 grams per 24. So what do you think where this protein came from? Okay.
Native kidneys, the same amount.
So
Native kidneys. Native.
native, anyone for recurrence? Okay, so keep that case in your mind and we'll keep going, okay? So essentially, how much of this protein that you're seeing on day 6 is actually coming from the native kidneys versus the renal allograft? And the work was done in the past in 2 sets of patients. So this is a prospective cohort of patients that were done at essentially Henry Ford in Michigan. And what they did was they took 14 patients who came to the transplant and they followed the protein by protein to creatinine. The protocol was every week they were going to check it. And what they showed was that most of the patients actually had a sudden drop in proteinuria, and by 8 weeks, they've actually all normalized. And they took some of these were deceased donors, some of them were living donor. And what they ended up doing was took one from each group and did a renogram and showed that the renal perfusion had gone really low. So the kidneys actually, the native kidneys stopped functioning very early on. So that was, that's out there in the literature that the pre-transplant proteinuria for people who go to transplant diminishes very quickly. We did a similar study, but in our program, this wasn't prospective, but we have a standard way of following patients where we actually do protocol biopsies and we collect urine before the transplant. We do a 24-hour urine collection for people who are preemptive, and we do follow-up depending on the disease. So if they don't have a high risk for FSGS, for example, they would get proteinuria checked at 3 weeks or 2 weeks post-transplant. If they're high-risk FSGSs, we will check them daily, or if we're suspicious of their disease, we will check daily early on. But essentially, that gave us a group of data sets that we can use. And we essentially looked at 115 patients who had preemptive transplants where we had the 24-hour urine collection within 3 months from the transplant. And then we checked the proteinuria at 3 weeks in this cohort, which is when they were ready to go home from the early post-transplant clinic. And we did surveillance biopsies at 4 and 12 months. And essentially, that's the patient cohort that we had, their average age, predominantly Caucasian. And essentially only a fraction of them were actually on dialysis because they needed to be making urine to have that 24-hour urine collection done. And as you can see here, regardless of the disease, the cause of the end-stage kidney disease, you've got a widespread of amounts of protein that you're detecting. So the disease that they come in with does not necessarily dictate to you how much protein you're going to find. And this is what we found, that essentially the proteinuria came down very quickly as well, but you had some people who were elevated, as you can see here. And if we were to look at the pre-transplant proteinuria and the proteinuria at 3 weeks, the line of identity, that 45-degree line there, is essentially anything below it, you've had a decrease, anything above it, you had an increase. And the ones that had an increase, if they had a level at 3 weeks of over 1,500 milligrams, if you biopsied them, they had glomerular lesions, and if they had an increase above 500 milligrams, they had the same. So when you do biopsy them, there's a glomerular lesion. So that raises the question, which is the end of this set here. That patient that came in with 3 grams and essentially minimal hypoalbuminemia, if that person, you think that they're truly high-risk FSGS recurrence, what would you want to do to them post-transplant should they have a recurrence? Treatment options. Correct, so you probably want to do plasma exchange. Most people would do that. You'd want to give them rituximab. You'd want to at least know that they've had some disease recurrence. So if you end up with someone who comes like this and you transplant them, you're really hampered in knowing whether or not they have disease recurrence if they are making urine from their native kidneys. There's other reasons why you would want to actually eliminate the proteinuria pre-transplant. And Dr. Hanna will go over several more indications that are more common in pediatrics. But in the adult population, the most common reason we want to make sure that there's no proteinuria post-transplant that's coming from the native kidneys is what we are trying to monitor for essentially FSGSs, high-risk FSGSs, where you need to know that if there's an early recurrence, you know that it's there. IgAs, membranous, MPGNs, PGNMIDs, all of those stuff, you're not too worried about. to detect that early with protein, and you can probably wait and see what happens over the first several weeks as you monitor the proteinuria to see whether or not it resolves. If it's coming down, it's great. If it's coming down and then going up, you know something is amiss. But the FSGS is you really want to know that the protein in the urine is absolutely from the transplanted kidney. So if this patient came in, just when we're on the same topic, so if this patient came in on dialysis, not making any urine at all, or for some reason they had their kidneys removed, if you find a little bit of protein post-transplant, you know, that albumin comes back at 500 milligrams, is that FSGS recurrence on the first day? Because essentially ischemia or perfusion injury can give you some albuminuria. So it's not, but at that point what you're going to be doing is you're watching it go up. So again, what you're trying to do is make sure that the protein that you're seeing early post-transplant is actually from the transplanted kidney. Other reasons include in the adult population, in membranous in particular, is if they have severe hypoalbuminemia. The surgeons don't like operating because wound healing is worse, and at the same time there's a hypercoagulable state, and then they want that to be diminished. So we want to eliminate that proteinuria. I will let Dr. Hanna proceed with his talk, and then we will have a little discussion about the various options. There was a process that was developed by one of our transplant surgeons a few years ago. And then we're actually looking at the pediatric literature as well for it, and the data that we have for it right now. Dr. Hanna will go over it, and then we'll have a discussion, okay?